Dr. Taylor, we heard about how you've achieved results, primary care clinics there. You mentioned achieving increase in vaccine given, cancer screenings that are completed, and improved management of high blood pressure patients. Emergency room patients count is down. So explain to us how we could scale your effective model so prevention and care coordination happens across the country. And specifically, are physicians empowered to do this now, or are there federal barriers?
Thank you, Senator Grassley. Thank you, Senator Grassley, for the question, and appreciate the opportunity to answer that. So there's really two parts to your question, and one is regarding how we scale these efforts. And I think there's always difficulty in scaling something you do locally because healthcare and how we deliver it is local. So you have to have different solutions in different places for what makes sense for the patients and their communities. So you have to have the flexibility and agility to put forth a solution in one community versus another. In a particular area in urban Iowa, we don't have a lot of transportation issues, but you get to rural Iowa or rural Midwest or other parts of the country, and we have significant issues getting people to their doctor's appointments. So simply stating that transportation is something everyone needs to work on, as an example, would not be it wouldn't be something that you would say everyone needs to do the same thing. The point is you have to have flexibility in what your efforts are. We really need a handful of things universally across our country for the physicians locally to be able to put forth their initiatives, and that is we need data, and then you need your own tool, regardless of what that is, but you need, whether it's telehealth or care managers or technological tools, but you need data, tools, and then you need time, which means you need personnel. You need doctors and nurses to be able to respond and do the outreach and these extra things that are important for coordinating care beyond what's done in just the office visit. And so these extra things that we're having doctors do that take up more time for paperwork and phone calls that are not patient care, we need to relieve them of those burdens so they can spend the time coordinating the care instead.
Are there any federal red tape problems to do what you just said?
Well, there are several. One of which is that we don't have a reimbursement model currently in the fee-for-service side, which does appropriately reimburse physicians to do these extra things beyond office visit care. At least in Medicare Advantage and sometimes in the ACOs, we have more flexibility there. There's supplemental benefits, there's incentives that you can provide to primary care offices. And so when I've worked with various Medicare Advantage companies over the years, they incentivize primary care offices to make sure that your patients were seen, to work on the preventative measures, to make sure that quality of care was ensured. And so making sure that we have a predictable but yet able to reimburse us for the extra things beyond office care is one of those. And then there are multiple, which we'll be happy to work with you afterward and provide a detailed list of the small details which just take up an enormous amount of physician and nursing time.
Thank you. And then I want to ask Ms. Grabert, your testimony spoke about the 2018 expansion of telehealth in Medicare Advantage and Medicare money, and laid the groundwork for expanding telehealth utilization during the pandemic. In fee-for-service, Medicare telehealth expansion costs money. Is Medicare Advantage an effective model for expanding primary care benefits for seniors while also lowering Medicare spending?
Thank you for the question, Senator Grassley. Yes, I do think that Medicare Advantage is the program to look at for expanding primary care. One of the things I mentioned in my written testimony is that Medicare uses what's called value-based insurance design, or VBID, for Medicare Advantage plans. And in those experiments, which are similar to ACOs on the fee-for-service side, they've identified a number of services that you may want to think about potentially treating in the same way you looked at telehealth in the 2018 bill. Some of those examples of services under VBID for Medicare Advantage are cost-sharing reductions for medications, non-emergency medical transport, which has been mentioned a few times already, healthy food and grocery options, annual wellness and routine physicals, smartphones, broadband and internet, roadside assistance, and minor home repairs. These are services that Medicare beneficiaries are getting under MA through the VBID model, but those are small in nature, and they should be considered for a nationwide expansion.
Thank you.
Senator Johnson.